else. I am a gastroenterologist, and you demuted me.
No, you just need to turn your sound off because you're in the meeting.
And I started a year and a half ago as an endoscopy fellow here in Vignette, and I'm doing a PhD in this one.
Okay, Sander?
My name is Sander Schmitz. I am a junior fellow of David. I started about 6 months ago. I also will start a PhD in endoscopy. My focus now is getting more comfortable in the more difficult EMR, so like the SMSA4 and 4+, a bit more anticipating difficulties, hopefully not, but anticipate complications and dealing with the complications without any, problems or significant problems.
So your focus for today then, Sander, is going to be focused on avoiding complications.
Avoiding, absolutely.
Okay.
Yeah.
All right. We'll try and help with that. Try and avoid some complications today. Yes.
I'm Lieve Peters. I got my education in Leuven. I worked in a hospital in Mol for 9 years. Due to familial reasons, I started in a polyclinical setting where I also do especially endoscopy and taking away smaller polyps. When I have bigger polyps, I refer them to Mol and I try to take them away by myself. And now I'm here to improve my skills in taking away larger polyps.
And so, Lieve, what sort of size of polyp would you say that you feel comfortable with right now?
It depends on if it's granular or not.
That's a good answer to that. Okay.
The largest polyp I took away was 1/3 of the circumference, but it was granular. I felt rather confident because I could lift it up. It was no resection, but with bigger adenomas, lesions that are more flat.
Maybe non-granular, flat,
Yes,
serrated. Okay.
Yes.
So your focus of this might be a bit of assessment and decision making about should you do it or should you not do it, and then trying to move your competence, if you like,
Yes.
from the granular, maybe a little small, to the bigger granular and the flatter polyps.
Yes.
Okay. Nice to meet you. Yes, Celine.
Hello, my name is Celine Morrison. I'm living in Hasselt, but I'm working in Genk. I started in Genk a half a year ago, and I'm here as a fellow also for 6 months now, 2 days a week, to improve my endoscopy skills. And I'm here today also to improve my EMR education.
What do you want to focus on today, Celine? If you can say one thing about your EMR that for you is not where you want it to be, what would it be? And what can we make your focus of today?
I'm still focused myself on also the small polyps. It started the injection. I mean, it starts from the beginning. A good injection and the technique of my loop to
place your snare.
my snare.
Okay, so we're going to focus on that for you. And I think that, Celine, you've been working with me for a bit more than half a year, haven't you? And I've seen dramatic improvements in your technique over that time, but indeed, we can do more. And so let's work today on snare placement technique for you, and doing it well and doing it slowly. Okay, and Maria Eva. So Maria Eva has just joined us from Italy. So why don't you introduce yourself, Maria Eva? I think it's fair to say that you are not at the level of the others yet.
No. No, I'm currently a trainee in Verona, Italy. And I'm here just for a short period to improve my basic skills in endoscopy. So I'm more focused on doing my endoscopy technique and basic polypectomy.
Okay, so we certainly can focus on some of that today, but particularly also tomorrow. And Maria Eva, you are one of that breed of people who will come, I think, in the future, or people whose theory is here and whose practical is here. And so that's usually the opposite way around. Most people's training is their practical is here and their theory is nowhere. And then their practical needs upskilling quite a bit, but their theory really needs a dramatic start. So Maria Eva will surprise you all with her theoretical knowledge, and we will help you, Maria Eva, with your practical skills. Okay. Peter Jan, come and show yourself to the camera and tell everybody about yourself and what particularly you might want to get out of your EMR training, even though it might not be today, because Peter Jan is doing the actual work of the department today in the other room. So tell me.
So I'm from Brussels. I'm a consultant since August, and I'm in training 1 day a week here in Ghent, and will start my fellowship in October full-time for 2 years. And I've been training EMR here quite a bit already. I think SMSA 3 and maybe 4 under supervision. But I still think I can improve in technique for the details of especially for the bigger resections, the difficult positions, getting my position right, getting my snare placement right. So I think those are most important, I think, for now.
Okay. Perfect. All right. So we've actually got a very broad range of focuses here, haven't we? We've got from the general getting around, and of course getting around is very important, because if you can't get around, you can't do polypectomy. So I think that while Maria Eva is way below everybody else in terms of technique, that is a very important thing we can focus on today, and we will use Scope Guide throughout today. I know that those of you who are probably from the UK are using Scope Guide all the time. In Belgium, they're really not using it at all. I don't know, Eva, whether you're using Scope Guide, the tracking device for the scope, not at all. So that we will also focus on today, and how you can use that to optimize your position, to proactively problem solve about how your polypectomy could be easier from the colonoscopy point of view. And then we've got something on that. I like that you said adverse events. I have a whole presentation on that. Maybe you knew, and I have a whole thing about technique. So those are great, and those are the objectives of today. It is probably at this point interesting to, does everybody, okay, let's start with, do people not know what the SMSA score is? I'm going to tell you about it anyway. So I'm going to start the presentation now. So you can stop screen sharing, Lynn, and I'll start screen sharing from the other one. We just need to make this a little smaller so I can start the presentation. So this is going to be about 15-minute presentation now, and then we can start with the live cases. So we're just going to go through the cases today and assign them to people who I think is relevant. So we have got our expectations, which we set, and we have got a list of 4 patients here. The first patient has got a 20-millimeter polyp, 35 centimeters inside. It looks like a flat polyp, and actually, Leva, it makes me think of you, that you said you wanted a flat polyp, a non-granular polyp. That's exactly what that is. So maybe you want to do that case together with us. The second patient, I want to refer a patient who has scope with an IFOB. He had a 50-millimeter lesion in the cecum, which I removed. Adjacent to the valve, he had a 4x4 LSTG, which I left in place, and another one in the ascending. The expectation of this patient is that we will do one of these probably today, not both of them. I think that is my practice is not to take on 2 hardcore things at one time, because if you have 2 hardcore complications, you're really going to make patients suffer for that, even though they may well be very, very pro you doing both at the same time. I think you have to rationalize that with them. And so that one, I'm thinking, I'm not sure yet. The third case, the granular polyp 25 in the cecum. I wonder whether it doesn't look like it's involving the ileocecal valve to me. So maybe that's actually one for you, Tumi and Mohammed. It looks like maybe at the sort of maybe current extension of where you're at.
Yeah, sure.
Then we have got, so I'm thinking of the other fellows that I've got here, and I'm thinking Xander, I'm thinking Celine. I'm thinking perhaps the granular thing is something that Celine might want to take on. So that's the second patient. And then depending on time, And the fourth patient is a highly complex thing. So I think that Xander, that one's for you together with me, I think, because if you just look at the image of that fourth one, we should have a serious discussion about whether that is for EMR or not. Okay, Pitian, everything good? Okay, so the first thing I want to talk about is I make absolutely nothing at all about repeating myself, because I think that this is the most important thing you're going to learn today. So you might think I came on an EMR course and it was all about technique and I just want to be able to do polypectomy, but no, I think most of polypectomy is about the decisions that you make, and you make the right decision and the patient gets a good outcome. You make a decision not to start, often that is the right decision. If you make a decision not to start but let someone else start, that is often the right decision, and maybe you become that someone else in the future, right? And that is the whole point, I think, of you attending a course like this, that the number of cases that you don't start because you feel you need to send to someone else, not that they're cancer, right, but they're just too difficult, that will reduce over time if you follow the pathway that we set out. So here is a little bit our deconstructed approach to polypectomy. Throughout the day, Lobke and I will try to drive your thinking into these boxes, because actually I think that that is a way to understand between each other what we're talking about. Because of course there is a whole load of theoretical stuff out there about polypectomy. I say some words like Sano, Kudo, and what does any of that actually mean in terms of relevance to patients? And so actually, when you start to put it in these boxes, you start to have a better understanding of why we do what we do in polypectomy, and a standardized approach to not only patients management, but language that we can apply to patients in terms of polypectomy, and that between professionals, we can communicate in the same language. So for example, Xander, does that polyp you're looking at have a demarcated area? Now, to Xander knows exactly what I mean, because I spend my whole life discussing that with him. But do you know what that means? Do you know what that means? Maybe you do, maybe you don't. If you watch the introductory webinar for this session, you potentially do, but I will drive that point home today as one of the boxes which we can discuss to standardize our idea about polypectomy. So it comes down to this. First question always, when you see a polyp, is not, oh, should I take it out or not? It's, does it have cancer in it or not? Now, the reason why people skip that step is because the majority of polyps that we find under 10 millimeters in size don't have cancer. You can pretty much guarantee that, because the risk of Xander, what is the risk of a under 10 millimeter polyp containing cancer, roughly?
Less than 1?
It's much less than 1. Is it less than 0.1? It's probably about 0.1 or less, right? So therefore, as humans, we tend to skip steps which never occur, or we think never occur, okay? But as soon as you start finding polyps bigger than 10 millimeters in size, the risk goes up 20 and more. What is the risk, Celine, do you think? What is the risk of cancer in a polyp above 20 millimeters in size? Any polyp, roughly. I'll give you some options. Is it 1, 5, or 10%?
5.
It depends on the population of lesions in that group. But yeah, it's between 1 and 5%. And if you're going for a big lesion, let's say a lesion of 80 millimeters in size, it's much higher. It can be up to 20%. And we have a scoring system to help you make that decision based upon all those things. So first step, is it cancer? I'm going to ask you it every time we see a polyp today. Second step, okay, it's not cancer. Should I be the one doing it or not? It's actually missing from this diagram. What are my competencies and how do I match my competencies to the requirements of the polyp, right? And sometimes, in your case, the patient, the situation, etc., because that really comes, if you have a patient who's completely asleep and an anesthetist is taking care of the medical side, you can be a proper surgeon. Whereas if you have to be the physician as well, and you have to, I'm not talking about appropriateness, I'm talking about managing the medical situation at the time, then it's a different discussion, and we will touch upon that for your practice. And then, okay, I've decided it's not cancer, and I'm the person to do it, right? What technique should I use to do it? Should I do it in one piece? Should I do it in multiple pieces? Should I do it hot? Should I do it cold? Should I do it with a snare? Should I pre-incise it? should I think about full thickness or some other technique? Because I don't think that I can achieve my stated goal here, and that is one piece or piecemeal with the techniques which I'm comfortable with. And then, okay, and now we get to the part where maybe most people coming on an EMR course think they come here to talk about, and I've spent ages talking about something else. How do you actually do it? And technically, how do you do it? So all of the things that you told me, every one of them, I think, was focused on this. How do I actually do it? Your adverse events, your flat lesions and more difficult polyps, your snare placement technique, all of that was how to perform. And then I would argue that there's a very important thing that we must be able to talk about, which is, okay, say 10 people approach the same polyp. How do we say which one went well and which one went badly? And so we have a competency framework, which we'll show you throughout the day based upon this structure, which can answer that question for you in a necessarily subjective way, because everything that humans do in terms of assessment, and my assessment may be different to Lobke's assessment. It tends to be that mine is more harsh than hers, but we'll see how it goes during today. What is the quality of that procedure being performed? So let me just give you a little bit of theory. We've got about 10 minutes of this, right? I think these are important things so that you understand what we're talking about. The cancer thing was in the webinar. Now, I will nail it down today in the cases, but I expect that you already have some idea about the decision-making between cancer and not cancer. Does it have a demarcated area? And what are the other 4 parameters which determine the risk of cancer in a polyp? But we will go through that at the time. But on the concepts of hot versus cold, maybe, Zander, you can give me some of the benefits you think of hot snare polypectomy.
Well, you use diathermy, so you not only cut, but you ablate a piece of, or a small extra margin.
So what you're saying is, because you find polypectomy difficult and you only want to take a small number of pieces, you want to use diathermy to assure your margins?
No, you need to have, the lateral margins need to be wide enough, but if it's a more risky polyp with a higher risk of possible cancer, you have a deeper layer of resection. Okay,
so I think I can agree with that. The hot snare polypectomy gives you a deeper resection in the submucosa than cold snare polypectomy. The cold snare plane is through the muscularis mucosa. The hot snare plane is much deeper. Okay, any other benefits of hot snare polypectomy anyone else wants to suggest?
Ischemia.
Do you mean that
tissue is not viable, the tissue around?
Okay, so that maybe it doesn't give recurrent polyp later, do you mean?
I mean that the tissue next to the polyp also is chemical, so doesn't get and isn't viable.
Isn't viable. Okay, so therefore cannot come back later. Or I understand. Yeah.
I guess in a certain type of polyp. So, for example, if you've got a pedunculated polyp where there's a potentially moderately sized vessel in the middle, the application of heat immediately would reduce your risk of immediate bleeding.
So I think that's right. Actually, we want this course to focus on flat polyps, but you're absolutely right. And I think what I'm talking about here, and it's a very important point you've made, is for flat polyps. And for pedunculated polyps, the use of hot is totally different. Why is it totally different? Because you have a stalk. So you have a protective thing between the mucosa and the muscle layer and the diathermy or the electrosurgical energy that you're applying. So for pedunculated polyps, I think it's very clear. Hot snare polypectomy is preferred. So what have we got here? Well, these are the benefits of cold snare polypectomy. Let's start with that. So you don't get delayed bleeding, you don't get perforation, you don't get delayed perforation. But maybe the only downside is you get a superficial specimen. This is the one I agreed with of yours. I don't agree with any other benefit of hot snare polypectomy over cold snare polypectomy, because you can, for example, for yours, Lever, for cold, you can just take a wider margin of tissue to achieve the same thing that you can achieve with diathermy. So the kind of question is, are you willing to take the risks of hot snare polypectomy to achieve what you could anyway achieve with cold snare polypectomy? And so here are the risks of hot snare polypectomy, and they are a problem. They are a significant issue when we're talking about patients. So what happens to patients if you achieve one of these things with your hot snare polypectomy, they stay in hospital longer. They might have to be woken in the middle of the night to come into hospital with bleeding. They might need a blood transfusion. They may die. We had a patient recently who died in bed at night from bleeding. It wasn't actually from the colon, was from the esophagus. Was a patient in sheltered accommodation who said that they had someone at home with them because they technically did. They had a bell. They couldn't press the bell. So diathermy, electrosurgical energy is not benign. We are now talking about smaller polyps, but in terms of equivalence, it's pretty equivalent in terms of complete resection rate, polyp retrieval rate, and rates of delayed bleeding clearly favor cold snare polypectomy. This is what I was talking about before. So this is the line, the plane of cold snare polypectomy. Here's the polyp in pink. Here's the submucosa with these lymphatic dots, and the muscle is in red at the bottom. And here's your cold snare plane. Here's your hot snare planes, so kind of SM1, so SM2 levels. We are now talking about smaller polyps, but in terms of equivalence, it's pretty equivalent in terms of complete resection rate, polyp retrieval rate, and rates of delayed bleeding clearly favor cold snare polypectomy. This is what I was talking about before. So this is the line, the plane of cold snare polypectomy. Here's the polyp in pink. Here's the submucosa with these lymphatic dots. And the muscle is in red at the bottom. And here's your cold snare plane. Here's your hot snare planes, so kind of SM1, so SM2 level. So we're talking about SM1, 2, 3 as thirds of the submucosa. And here, the snare is usually between the SM1 and SM2 layer. And what happens when you do that is that actually is very interesting. People say to me, well, you know, you see all these big vessels in a hot snare defect. Should we coagulate them? Well, actually, no, it's the ones you don't see, which are responsible for hot snare polypectomy delayed bleeding. What happens is the electrosurgical energy injures those invisible blood vessels, and later they start bleeding during the ulcer formation that occurs between 24 hours afterwards to up to 3 months afterwards. But the bleeding tends to occur within 24 to 48 hours. This is a hot snare specimen. And what is the difference? Well, it's really the thickness of submucosal tissue. So with cold snare polypectomy, you kind of often don't get any submucosa. With hot snare, and here you have an underwater EMR. I mean, I think that is accepted that takes bigger pieces and bigger specimens. So the differences then clearly between hot snare and cold snare is you get more submucosa, a thicker submucosa, but the muscularis mucosa is usually obtained in both. Okay, so we talked about small polyps there, right? But what about larger polyps? So this is the target for cold snare polypectomy, but there is another target for cold snare polypectomy, and that is the sessile serrated polyp without dysplasia. So if you don't know what a sessile serrated polyp with dysplasia is, I will point you to some resources to figure that out later. But a non-dysplastic sessile serrated polyp, the majority of them, probably there's only about 6-7% which are dysplastic. If you look at the big data sets, so 95% of serrated polyps are non-dysplastic and can be removed, therefore, with cold snare polypectomy. So if we now look at this algorithm, we have got a cold zone, and that's actually the majority of polypectomy. I think probably 96% of all polypectomy anyone ever does should be being done cold. Why? Because most of the polyps are less than 10 millimeters in size, and if they're not, they're serrated and non-dysplastic. So summarizing then, avoid hot if possible. Why? Because it has defined and problematic risks for patients. And in my mind, if there is no benefit to the patient, you don't need to apply hot snare polypectomy. So therefore, cold for all polyps under 10, ESGE guideline, and now serrated lesions without dysplasia. Anything else for cold snares? You might say, well, okay, fine, but what about bigger polyps? Well, bigger polyps are very difficult to remove with cold snare polypectomy properly. Often with a big tubular villus adenoma, for example, there are some people who are saying, well, okay, I have a huge 35, third of the circumference granular polyp. Let's remove that with cold snare polypectomy. In the duodenum, it tends to work. In the colon, in my experience, it is much more difficult to cut through these things. And you have to be quite good at it to get a nice resection plane. And so I think that those things are experimental, both in terms of, is it actually technically possible? of course, if you have cancer, you want a piece of submucosa to assess for the risk of invasion, and you don't obtain that with cold snare polypectomy. So